I think Dr. Dinesh didn't so, being a retinal surgeon, he didn't do vitrectomy in any of the cases. But we
I've already completed vitrectomy in all these cases because I removed the drop drop.
okay, these were the special situations, but routinely he does not do. And if you don't take care of vitreous, then I think our basic purpose of secondary IOLs is lost. In our technique, it's mandatory to do vitrectomy and take care of the vitreous, which is the biggest culprit uh, in secondary IOLs or situations of aphakia, PCR, and no PC. My choice is scleral fixated IOL. So these were okay cases. If you have situations like this where there is an iris chafing, the pupil is not constricting, because it's mandatory to have a small pupil, or you generally constrict the pupil with pilocarpine in iris fixated lens. If you have an SI or dilated pupil, you can't perform this procedure. Or if you have an iridodialysis or an iridia also, there is no iris, where will you fix the lens? So in situations like this, the best choice is scleral fixated IOL. And either you can do a Yamanas, or you can do an tuck technique, or you can do an glued scleral fixated IOL. The problem with iris claw lenses is it's a poor dilatation. Dr. Dinesh is a retina surgeon and he doesn't realizes the importance of dilatation. And he says, I'll keep my pupil constricted. If something happens like detachment, what will he do? The optics is so small, it's 5.5 millimeter optic. He won't be able to do a good vitrectomy. No peripheral base dissection. Patient will come again with a detachment. And the biggest problem doing a retinal surgery with this lens is the moment you do a fluid air exchange, it rotates, it dances like this. But it doesn't happen in scleral fixated lens. There is an ovulation, there is an iris shaping, and iris, there's a lot of pseudo-phacodonosis. So if you see the lens, it's dancing in the anterior segment. If it is dancing in the anterior segment, you will have a lot of complication like endothelial damage, and that was one of the reasons why Dr. Daljit Singh lens was discontinued. And since you are putting the lens on the iris, there will be a lot of pigment dispersion, secondary glaucoma. So doing this technique, he's inviting all complications. So what is desirable is insert the IOL where the lens is normal lens is there, that is in the posterior segment, and all of his IOLs, what he's doing, he's implanting into the bag or sulcus. So that is the best position, and you have to do an scleral fixated lens. So this technique involves good vitrectomy, good post-operative vision, and other problem is, see, one of these patient, this is an ACIOL, very good surgery done 10 years back. Patient had 6/6 vision. One eye patient came with, after 11 years, he came with pseudophakic bullous keratopathy. We did the specular microscopy in the other eye. The count was 1000 only. After 10 years of good surgery, what you are showing is a short-term results. After 10 years of surgery, patient realizes because of the IOL, he is at the verge of blindness, and both the eyes requires PK with removal of IOL. So, other procedures like this patient has an absorbed cataract. This is a child, and you can see we have done a scleral fixated IOL. You can see an haptic, and this patient is maintaining 6/18 vision with such a bad eye. And DSEC procedure, you can't do anything corneal procedures with iris fixated lens. You can see this, I have done a DSEC with this glued IOL, and you can see a good cornea, clear cornea, and the vision improved to 6/9 and still persisting with 6/9, and you can't do anything like this with iris claw lenses. Another patient, you can see a valve here, AC IOL. So what we did was remove this valve, did an scleral fixated IOL, and did it PK. This patient is still maintaining 6/24 vision. So to conclude, difficult roads often lead to beautiful destination. Slow and steady wins the race. So although it's a slightly difficult procedure, but long-term results are good. So I recommend all of you to go for an SFIUL. It's easy to combine with the various corneal procedures, and if you see the sutures versus scleral fixated results, almost it is same, and the problems like ovulation of pupil are less. So you can choose either of the way. You can choose to go like this way, eat ice cream, and you can make a mess, or you can go with a difficult way and have a clean surgery and good long-term results. Thank you very much, sir.
Yeah, I think first of all, I must thank Dr. Avninder, and then I think you should go to a island, paradise island, because what mind doesn't know, eyes don't see. He could not see 3 pars plana ports in any of my eyes, the ones which I operated, and he feels I have not done vitrectomy for those. He is showing you angle fixated IOLs, and he is saying it causes bullous keratopathy. I am telling him it is gone into the posterior chamber, and he says anterior chamber IOLs cause bullous keratopathy. I think you are living in a fool's paradise.
But
the thing is, we are doing it in difficult cases, cases where there is no posterior capsule, where I am not saying this is for 100% of cases. I am not stopping my phacos and started doing iris claw lenses. You are talking about Dr. Daljit Singh, who was putting iris claw lenses in all cases and not doing phacos. So what I am suggesting you is, come to me for a day, have a good night's sleep, and come to my OT in the morning. I'll show you how to do a good iris claw lens and have a good result.
no, sir,
Otherwise,
the basic
I
thing
thought
is,
you are staying, practicing in Delhi, a big national capital of a country, but probably you are living in a fool's paradise.
sir, the basic
The
problem
island where knowledge is limited. You have to open your eyes to the new world.
Sir,
And this is something which is easily doable for any veterinary surgeon like you.
So the basic
Please open your eyes,
the
sir.
basic problem is you are showing short term and the easiness of surgery. That's what I have commented. Ki easiness and
So
short
I
term results
have
does not
seen
end up into long term results.
These pupils do dilate, and Dr. Daljit Singh always show dilated pupils after this. Probably you have never seen my post-ops.
So for that I'll have to come and you have to publish long term data. Yes.
Yeah, that's true. So I think we end the debate with this.
Let me just I'm practicing in a part of the country where we have bulk surgeries being done by the anterior segment surgeons, where they are placing the iris claw lenses,
Okay.
multiple iris claw lenses, where they're doing 30 to 40 surgeries in a day, and some of them get wrong and they place iris claw lenses. And to be very frank, sir, removing such an iris claw lens is very difficult. If something goes wrong, means for a VR surgeon,
No, there is no complication here. Then why do you remove it?
no sir, if there is a complication, say one
No,
of the
I'm
seen
not saying that there is no complication. Any surgeon who says there is no complication means he is not doing surgeries.
yes sir, and
So
removing
the tucks get removed,
Yes, sir.
can get dislodged, and they can fall into the,
Yes,
but
sir.
they can again be reposited, and it can very easily be removed. The only thing is you have to remove that iris from the claw.
okay.
Okay, the same hook or the rod with which you have tucked the iris will bring it out.
So one of the cases showed marked uveitis with raised IOP.
So the reason must be, as Dr. Avninder said, that they have not done some complete vitrectomy, and there
That
might be some
because it was placed by,
residual lens matter staying
I
inside, because uveitis and other things, they occur with more with the angle supported lenses. There is no touch with the angle in these
I
situations.
totally agree. When you are doing a vitreoretinal surgery, and if you have an iris claw lens, it's very difficult to do surgeries in these kind. I've tried to expand. I also had the same problem what
Yes,
you
sir.
are saying. The main problem what it comes is ki the air comes into the anterior chamber, and the iris keeps on rotating, and the IOL keeps on rotating. Uh, then silicone oil comes into the anterior chamber. That's also one of the problems. But these are
Yeah.
few situations, not all situations. I think the incidence of detachment is not more than 2 to 3% in these
That
kind
is
of
true in
cases.
all the cases.
So if I have an iris claw lens, I'll prefer. I have done 2 or 3 cases with iris claw. The problems what I faced was similar, and I tried to remove it, but it was difficult maneuvering that, and doing vitreoretinal
I would
surgery.
agree with that.
Vitreoretinal surgery is a difficult situation.
So I think the similar situations do arise with the SFIULs also, because there is no demarcation between anterior and posterior chamber. The air comes in front even in those
Yeah, yeah.
cases. Any case of posterior capsule rupture, the air does come.
What I do is I do a PFCL silicon direct exchange in these kind of situations.
Yeah, that's
So
okay.
I don't go for an air. I go for a PFCL silicon oil exchange.
Yeah.
And if you have a
Except for
meniscus,
GRTs, I don't do that. I do air exchange. But normally what I do is I just use a soft tip and remove air behind the IOL.
Yeah, we have to conclude this session. Thanks to all those